Okay, hey guys, we're going to talk about Guillain-Barre. It starts on page 912, and we're just going to, actually this first video is just going to be on Guillain-Barre, and then the second one we'll do on myasthenia gravis. So we'll get started here. So Guillain-Barre syndrome, it's an acute inflammatory disorder that affects the axons or the myelins of the peripheral nervous system. So what's actually going to happen with this is similar to our MS that we talked about, that it's thought to attack the myelination of the nervous system. This is the peripheral nervous system. So what we're going to end up seeing is like an ascending paralysis, typically starting obviously in the lower extremities and working its way up. So that is the book actually talks about different thoughts and ways that it could be occurring, but this the demyelination seems to be the primary cause of GBS. So we're going to refer to this as GBS from here on out. So page 913, it talks about in some forms it's primarily the axons, and other forms the demyelination, the destruction of the myelin sheath of the peripheral nerves, which is what I was just talking about. It begins in the legs and moves up the body into the arms. This is referred to as ascending paralysis. So the patient is going to experience, starting in the lower extremities, like a numbness, a tingling, those the neuro symptoms that we talk about, the paresthesias, the all those things that we talk about when there's some kind of nerve issue and nerve conduction issue, so that it's going to likely start in the legs, and it's going to work its way up the body, work its way up the legs, up to the middle. It's going to start in the arms, come up this way, and then you're going to potentially get the diaphragm involved as well. And if the diaphragm ends up involved, then the patient has a huge risk for respiratory complications, may even need to be ventilated by a ventilator. So actually the next part actually talks about that on page 913. As a result, some patients require mechanical ventilation because of a weak or paralyzed diaphragm and accessory muscles for respiration. Healing occurs in reverse. The neurons affected last are the first to recover. So as this moves all the way up my body and it gets up to my face and up to my head, I'm going to have a lot of different, potentially we're going to have a lot of different things happen. Dysphagia, all kinds of not being able to stick the tongue out, almost like a stroke look, to be honest with you, that's going to happen because of all of the different nerves. If you think about when you were in health assessment, all the cranial nerves that you learned, and the different ones that affect smiling and affect swallowing and affect blinking and affect hearing and affect all those things, these are all going to be affected potentially with GBS. So if that happens, then you're going to see, like I said, it'll be a lot of stroke-like symptoms that you may end up seeing for this patient. But with this ascending paralysis, it starts healing itself in reversed order. So if, for instance, my whole body's paralyzed and I'm on a ventilator and then I lose the ability to swallow, although obviously if I'm ventilated, I'm not swallowing, but let's say I come off the ventilator, first things that are going to heal would be the stuff up here first. If I had any visual issues, hearing issues, speech issues, swallowing issues, all of those things are going to come back first. So it regenerates itself in the opposite order in which it came on. So the thing that's going to be fixed the last are the legs. In this person. So a mobility issue is going to be huge. This is something that we as nurses are going to be working with the patients and trying to help them with, because mobility is going to be one of our big priorities for this patient depending on how bad they get. Now, I'm obviously talking severe GBS. Not all patients will have it go ascending all the way to the top in the way of which I've just described. So over on 913, it talks about, and this is important to know, actually everything so far I want you guys to know. So there's the acute or initial period. This is 1 to 4 weeks in time that this takes for this to happen, okay? So you're talking 1 week to 4 weeks, a month. So 1 week to 1 month of the onset of symptoms, and then the total, where nothing is going to get any worse. So by that 4-week mark, they're going to be as bad as they were going to get. So if it's only halfway up, it's probably not going any farther. If it went all the way up, then it's done. It's not going to get any worse. So they say the majority of this stuff will happen between that 1 and 4 weeks. So think about that for a second. I'm sitting here talking to you right now like it's no big deal, and 1 week from now I'm totally paralyzed. Like, that's huge. That is huge. Imagine the depression, the anxiety, the fear, the powerlessness, all of those things that we're going to have to deal with our patients because they were just fine a week ago, and now they are in this totally helpless situation and can't move their own body, can't eat, can't breathe on their own. So so that 1 to 4 weeks is that initial period where their onset's going to happen and ends with no further deterioration. So 4 weeks. The plateau period, which is going to be several days to 2 weeks. So after that 1 to 4 weeks, they're going to just stay in this bad state, whatever is as bad as they got. If it's the full total paralysis, they're going to stay in this state for several days to 2 weeks. And then there's the recovery phase. So remember, this happened very fast, very fast. The recovery phase is long. So 4 to 6 months and maybe up to 2 years. And your book talks about how somebody who has that total paralysis where it went all the way up and they were mechanically ventilated, obviously we're going to be dealing with getting them rehabbed, and the ventilatory issues, respiratory complications, all of those things that come with that. Up to 2 years before they fully recover. And it says some patients don't fully recover, and then they have what's referred to as chronic GBS. So some don't have that full recovery like many of the patients do that have GBS. So 4 to 6 months. So again, my life changed in a week, and it took 4 to 6 months before I was better, and potentially up to 2 years. So remember, again, the psychosocial aspect of our patients, and what we would be dealing with and helping them, and how we need to help get them resources and support groups and PT, OT, dietary, everything that needs to come in, respiratory, in with these patients. So the next part talks about the etiology, and the book talks about how typically it's some kind of bacterial or viral infection that's going to cause the GBS. One of the big ones being Epstein-Barre. Epstein-Barre is also known as mono, so you probably have heard about mono, called the kissing disease. When people are, younger, they talk about teenagers getting mono a lot. So Epstein-Barre, it's a virus that people get from sharing bodily fluids, and many people are exposed to it, and it becomes latent in their body. They fight it off. It's no big deal. They have it forever, and then maybe later on in life, if their immune system is attacked, it may come back. And they can be contagious with Epstein-Barre for a couple of weeks, actually, even with no symptoms. So that's how this gets spread so easily. People don't even know they're sick. So that was one of the things that it talked about: influenza, cytomegalovirus, and then it also said with the recent Zika infections or viruses, viral infections that we've been seeing, that GBS has been seen in that too. So now they're going to include that in there as well. The book does a tiny little mention of that there have been some reports that vaccines can cause GBS, and you can look more into that if you'd like. I know that I've personally seen that in different things, and as a matter of fact, I was just talking to the clinical group the other day about, I believe that was a case that we saw in Flint with a certain vaccination. So the incidence prevalence, GBS is rare. It affects more men than women, but it just depends, again, on the viruses and how it attacks the person's body. So the next part of the book goes into all of our different interventions and things that we're going to do. You can see that I actually have quite a bit in here that I felt like was important on these 2 pages, so it would be very wise for you to read through all of these things. Under the physical assessments, make sure that you go under your key features and see those different things that I'm going to see. That's on chart 44.1 at the bottom of 914. Talks about the paresthesias, the numbness, the prickly feeling, the stinging that we were kind of talking about. Kind of reminds me of neuropathic pain, like with what our patients with diabetes will experience in, like their toes and their fingers and things like that. So they're going to have this kind of like this coming on part. It talks again on 914. It talks about all of those cranial nerves that it can affect. So it tells us we want to ask the patient to smile, to frown, to whistle, to drink from a straw. We want to assess for dysphagia. We want to see if they're able to gag, cough, swallow. The next thing that I thought was important and really interesting actually is that, so because this is affecting the nervous system, the peripheral nervous system, that's also going to affect the vagus nerve. And we know if the vagus nerve is stimulated that I can have what? I can have bradycardia, I can have hypotension. The book actually says it can cause a heart block and even put somebody into asystole because of how it can affect the vagus nerve. So that's a huge thing. Like we've got to have our patients that have GBS on telemetry and make sure that we're watching what's going on with their heart, make sure that we don't see any of those things happening that could cause them to have some kind of dysrhythmia, and then here we are coding a patient that really we should have just been supporting. So we have to be careful and very on top of this patient. This patient in fresh GBS is going to be in the ICU. They're going to be on the monitor. They're going to have, the nurse is going to have 1 or 2 patients. That's it. And I've taken care of a couple of GBS patients in my nursing career. The next part talks about diagnostic assessments. There's no definitive tool. Remember, like with MS, there was no definitive tool. There's no definitive tool for this as well. However, there are things that we will see, and same like with MS, we will see an increase of plasma proteins in the cerebral spinal fluid. Another thing is said that in the peripheral blood test may show leukocytosis in the beginning, but then it'll actually go back. And then over on page 915, it talks about some of the things that we can do to help the person in GBS. So plasmapheresis and IV immunoglobulin therapy. So if you don't know what those two things are, make sure you look it up. I'll give you a little bit of an overview. But plasmapheresis, this is where they're going to hook the patient up and take out blood, and they're going to separate the plasma from the actual whole blood itself, put the whole blood back and keep the plasma to get rid of those bad antibodies that are attacking the body, because this is all the body attacking itself. The virus has caused the body to develop these antibodies that is attacking the myelin sheath, essentially, of the peripheral nervous system. So they're going to take those out, hoping that the body will regenerate new good ones that won't attack the peripheral nervous system. The other thing being IV immunoglobulin therapy. These are human antibodies, so this is like a blood product. So if I'm going to give this, I'm going to be watching the same way that I'm going to watch if I'm giving packed red blood cells. When we give the PRBCs and we hang those up and we do all of those things that some of you have gotten to do, I know with me in clinical when we hang blood, and we watch for those reactions. And so we're going to be doing the same thing when it comes to that. And this is giving the patient nice new antibodies, hoping that it will stop the attack on the actual body and help regenerate it quicker. So those are a couple of things that talks about. On 915, 44.2 goes into a few things. I only highlighted a few things about getting the order for Benadryl and assessing for temperature a couple times a day, because remember, this person's going to end up immunosuppressed because the body's attacking itself. So you want to make sure that you're watching for any kind of infection. And then again, if the patient ends up with a paralyzed diaphragm and they end up intubated, airway management's going to be super huge for us. And airway, and so we want, obviously, we want adequate gas exchange for this patient, and we'll be watching all of those things. And it actually talked about chest physiotherapy, which, again, some of you from my clinical group got to see that done last week, which was pretty cool. It was the first time I got to see it too. We also learned about the cupping method that I showed you guys with the patients with cystic fibrosis. So that is something that I just noticed in there, and I highlighted it. And then over on page 916, it's going to talk about the cardiac monitoring again, the dysrhythmias, the things that we can do to treat the hypotension, the things that we can do to treat the bradycardia. And then once my patient is able to, is starting to come back around, that descending healing is happening, I want to try to get them to do as much as they can as possible. You notice if you have gone with me to clinical, every single patient, I make them do as much as possible as they can, because I'm not doing them a favor by doing it for them, okay? Now, obviously, if my patient is ventilated and sedated, I need to do everything for them. I got to passively move their fingers, I got to move their legs, I got to move their toes, I got to move their arms, I got to do everything, I got to move their neck, I got to turn them, I got to get them off their bony prominences so they don't get bed sores. But once this patient is able to start helping me with things, I'm going to have them do the maximum ability they can, because I'm doing them no favors by not. Even if they don't feel well and they don't feel good and they don't want to do it, I am actually helping them by making them do that. So remember to get that and keep doing that. It also talks about VTE prophylaxis, because we don't want them to get thromboembolisms that turn into PEs. So it talks about putting them on low molecular heparin. We know that is Lovenox. And then in the last part, it talks about home care, and actually this is where it talks about the patient going home in a way that much like what a stroke patient would go home. So make sure you just read through that. It talks about some self-help, some groups, some different things. There's actually a website that you can go look on for information on GBS, and I think that's going to be it for this one. Obviously, I'm almost at my 15-minute mark, and then your next one will be on myasthenia gravis.